Hi, good Friday morning to you all. This is the really kind of towards the end of our unit two or week two, but we're going to go ahead and have a quick discussion on some of our topics for the week. Most of it's going to be over infection control. I'm going to throw in some other things like medical terminology and anatomy as well, because they kind of group together pretty well. So here are our objectives for unit two. We're going to talk a lot about microbiology, aseptic technique, how it relates to you as a sterile processing tech, and how you can use medical terminology as it relates to those types of things, and infection control. So here are your assignments that are going to be due by Sunday. Your first discussion post is due on Wednesday. I know I'm doing this after that due date. It's just how my schedule ended up being this quarter. So make sure you're getting those in by Wednesday, but you still have until Sunday to do your two responses. Make sure you're getting two in for full credit. Otherwise, I'm going to dock points off. Also, be sure to watch your APA format for your citations. Those are the two things I typically take the most points off for. I also want to draw your attention to this here. This Unit 2 workbook it's a lot of points, a lot of questions on those workbook chapters, okay? So be careful there. And then I would also recommend, I didn't put it here, but look ahead to next week. I think there's another big point assignment that you may want to get a jump on, okay? All right, so we're going to start off with medical terminology because it's kind of like the language that everything else is going to be spoken in, because in the medical field, we basically use another language. So it can be daunting to learn medical terminology, but I pose this question here. Why is it important for central service techs to know medical terminology? Because you're going to learn to speak another language, essentially, because everything else you see, like on preference cards, on, just talking to people that are working up in surgery that you have to communicate with, they're going to be speaking in medical terminology. So you have to understand what they're talking about so you can make sure you respond appropriately or help them appropriately. Okay, so let's just dive into some of these basic medical terminology, um, like just the very core understanding of medical terminology, okay, revolves around these three things. So a medical term is going to have these parts. Now, every now and then, a medical term may not have a prefix, but medical terms always have a root word and there's always a suffix. The prefix may or may not be there, okay? So a root word is what the word really means, okay? It's usually found in the middle of the word or at the beginning if there's no prefix. It's the primary meaning, and it says the meaning of this can be modified by this prefix or suffix. A prefix always comes at the beginning, and a suffix comes at the end of a word or after the word root. Okay, so these three things are called word elements, and they're terms that can be broken apart or broken down and defined individually. And when you combine those definitions, it makes the entire med term. So we're going to practice breaking some of those terms down and building them back up and defining them. So typically in medical terminology, these parts here, word roots, prefixes, etc., are of Greek or Latin origin. And sometimes you're going to have two med terms that mean the exact same thing. And the reason why is because maybe one came from Greek origin and the other was from Latin origin. Okay. So that does trip students up sometimes. So that's just why you might see that. And typically we've just adopted one particular one that we use for a specific instance, and that just requires memorization, right? So it says word elements may contain all three of these or just the word root plus a prefix or a suffix. So typically it's going to be a word root with a suffix. The prefix may or may not be there, like I said. So when you're putting word elements together, we often require a combining vowel. It's usually just to make it easier to say, so it flows better. Usually our combining vowel is an O, Sometimes it's I, very rarely, but sometimes. So more often than not, it will be an O, and I'll show you here in just a few. So taking what we know about those three parts of the med term, how do you define that medical term? Okay, you start at the end of the word, even if it's a huge, giant, long word. Always start at the end. Find that suffix there at the end. Define it. Then you're going to go back to the beginning of the word if the prefix is there, whatever is at the beginning, okay? Define that part. And then you're going to just work your way through the word, basically going back towards the middle, and then define the word root last. So always start at the end with the suffix, go back to the beginning, and then towards the middle. So let's look at that. How does that work? Okay, so let's take this term, cholecystectomy. So the end term here, and there should be a T here, my bad, is ectomy. So I put a number 1 here because that's the first thing we do. This is a suffix. Ectomy is a suffix, which means, you look over here, excision, you're taking something out. So ectomy, go to the beginning, is chole. Chole means bile, and cyst means cyst, or sometimes bladder or gallbladder, commonly. So ectomy, cholecyst is how that would be defined. So we would say excision of the bile cyst, or we know that to mean gallbladder. Okay. So let's look at some common terms here that honestly, I would recommend making note cards of. They're very common. You're going to see them all the time. You need to memorize these. Okay. So these are suffixes that all mean pertaining to. So like I said, there's going to be some that are repetitive, and you're going to learn which one goes with what. Okay. So all of these come at the end of the word, the medical term. They all mean pertaining to. So if I'm going to define that med term, start at the end. Pertaining to what? What are we pertaining to? If there's a prefix at the beginning, pertaining to, a prefix typically is going to change like how many of something, like a number, a shape, a color, whether it's there or not, absent or with. So pertaining to, say 4 of something. So pertaining to is always at the end. So suffixes, some other ones that don't mean pertaining to, you're going to see these a lot, okay? These are all, and I tried to make it more pertaining to surgery, okay? So these are all things you're going to see maybe that come up on a preference card that will be like a surgical case that you might have to pick instruments for or something. So ectomy means surgical removal or to excise, to remove something. So taking something out. Otomy, now notice this and the third one are very similar. So watch your spelling. Otomy means incision into. You're cutting into something. So when we're trying to figure out what we're cutting into, we go here, otomy at the end. Cutting into what? We go to the beginning of the term. Maybe it was gallbladder. Or maybe, now remember that term cholecystectomy was we were taking it out, but if we were just cutting into it, we would say cholecystotomy, which is kind of an odd thing, but it could be done. Ostomy, this S here, ostomy is you're just creating an opening. So it is slightly different than otomy. Okay, ostomy, you're just creating an opening, maybe like a little hole. Okay, raphe, notice spelling here is 2 R's, 2 R's H. It's kind of a weird one. Raphe means to suture, close something with a suture. Tome, notice it's different than otomy. Otomy of incision to ends in a Y. Tome is the instrument that you're going to use to cut. So you might have a dermatome, which would be an instrument used to cut skin or skin graft. Size is to cut, so like an incision. Size, to cut. Pexy means surgical fixation, so that means you're basically putting something back where it goes, okay? You could have an orchiopexy. Usually we do those on young males, like age 2, 3-ish. where the testes maybe didn't descend. So orchiopexy, fixation, putting it where it goes. Itis is inflammation of something. So inflammation of what? You define the term, go back to the beginning. And then pathy is disease. Pathy. All right, so word roots. These are, remember, the word root is basically what the entire term is about. And then the prefix and suffix just maybe alter what that term is really referring to. Okay, so you'll see these pretty often. Arthro, and notice here, this slash with the O is your combining vowel to combine with the suffix. So arthro is joint. You could do an arthrotomy, make an incision into a joint. Colo is colon. Sometimes they make life easy and it's very similar to what the term means, but not always. Hystero is uterus, like a hysterectomy. Now notice here if I say ectomy as the suffix, I drop this O combining vowel because ectomy already ends in a vowel. So if I say hysterectomy, I drop the combining O. Because if I just said hysteroectomy, it's like an extra syllable. It's too much. It's too extra. We don't need that. So hysterectomy is how you combine it with a suffix that started with a vowel. So uterus. Litho is stone. So you could have, you could remove stones from the gallbladder. So you might have a lithotomy or lithotripsy to break up the stones. Osteo is bone. Gyne is how that's pronounced. Gyno is woman. So gynecology would be the study of women. And then cranio is skull, crani. All right, prefixes. So some common ones here. Prefixes come at the beginning of the term and they're not always present, remember. But if they are present, it alters what that word root means. So like I said, it's usually pertaining to like how many of something, where it's located, whether it's there or not. That's what prefixes mean. So a or an means without. A or an, without. Dis is apart or away, like maybe it's displaced, right? Apart from where it should be. These sometimes you'll have opposites as well. So hyper and hypo are opposites. Hyper means like if you know someone who's super hyper, you know, they're always up here, right? They're extra. They're always have high energy. So hyper is above or excessive. The opposite is hypo, below or deficient. So hypo, think of a hippo. He's heavy, he's low to the ground. So hypo is below or deficient, not enough. Per means through, like percutaneous would be through the skin. Peri is surrounding or around a structure. Pre is before, and then sub, like a submarine, is under or beneath. Sub, under or beneath or below. So memorize these. So with MedTerm, we also, refer to abbreviations because they're just as important. So these aren't necessarily terms that you break down, but they're terms that you're going to see very often. So a triple A is how we refer to this as triple A. So it stands for abdominal aortic aneurysm. This could be an emergent surgical procedure. If you have a ruptured triple A, it is very emergent because they could be losing a large amount of blood very quickly. That the aorta in the abdomen is very large. It comes right off the heart. AKA is not what we typically refer to as like also known as, right? It's above the knee amputation. You could also have a BKA or below the knee amputation as well. BSO is bilateral. This is a fun term. Look how big this is. Salpingo-oophorectomy. So even though it's a big long term, let's try to define it. Ectomy, we've learned as excision of. Go back to the beginning. Salpingo, this term here, salpingo means tube, a fallopian tube. And then oofer is ovary. So excision of tubes and ovaries. So bilateral means both sides. We call this next one a cabbage. Not like what you would eat. I wouldn't eat personally, but cabbage. I don't like cabbage. Anyway, stands for coronary artery bypass with grafting. So maybe you've heard this on a medical show or something. You're like, I don't know what that means. Coronary artery bypass with grafting. So if there's a blockage in the heart somewhere, they got to go around it so the blood still gets to the heart muscle. EGD, here's another long, crazy term that you probably would have just ignored previously, right? Oscopy is going to be to view, or you're viewing something. What are we viewing? Go back to the beginning. Esophago, so I'd break this first one down. That's the esophagus. And gastro is another. Stomach. And duodenum is the duodenum, or the first part of the small intestine. So this is an interesting example because this term particularly has 3 word roots and no prefix. All 3 of those are word roots with the suffix at the end. So you can have multiple word roots. It's pertaining to all of them. So you're viewing all 3 of these things: the esophagus, stomach, and duodenum. So you're putting a tube down the mouth and looking into those things. I and D stands for incision and drainage. So we'll make an incision usually into something that is gross and abscessed, infected, and we need to get all that infection out, drain it. And then MIS stands for minimally invasive surgery. So they're kind of moving towards MIS type of surgeries here. It's better for the patient, usually quicker recovery. Minimally invasive. All right, so understanding the surgical approach and purpose. So this is basically, how does it apply to you in your job? You're going to be checking the surgery schedule every single day if you're working in sterile processing. You're going to look at that, and you're going to see the schedule, see what's on the board. What are these patients coming in for? That way you know what you need to help those people, okay? So you're going to compare what you're pulling for the case. You're going to have a list of, okay, these are my surgeries I have to prepare for today. And then, am I pulling the right things? You have to understand, like, if you were doing that, let's say that AAA, the abdominal aortic aneurysm. That's what your card is for. That's what the surgery is for. But, you're starting to pull things for maybe a small vascular case on the arm. There's going to be a difference in those types of instrumentation, supplies that you need. So you need to understand that those two are very different things, okay? So you're going to use your med term to understand those procedures. Another good example, making sure you read those suffixes carefully, because there is a big difference in something that is scheduled for a cystectomy versus cystoscopy, okay? Oscopy is to view, you're viewing. Cysto here is the bladder. And then we said ectomy was to excise. So it's very different to just view something. You'd need a scope to view versus excision. You'd need a lot of instruments for making those types of cuts and dissections for cystectomy. So know the difference in the two and make sure it matches up with what you're pulling, right? You're going to look at the entire schedule for the day, not just, one at a time, because what may happen is, Dr. So-and-so may have 10 cystoscopies in a row. Do you have enough supplies for 10 cystoscopies? Do you need some of those trays back? Are you going to have to call up to the room and say, hey, when you're done with your first 2 cystoscopes, send them back immediately so we can have them reprocessed for the end cases at the end of the day. So you're constantly looking for those types of things, checking with what you have, and communicating with the OR. That's super important. Okay, so just a quick conclusion on MedTerm before we move on. You have to have that basic understanding so you can read the surgery schedule and you can help things move smoothly in the OR. That is, you guys are vital for that part. You have to communicate with people upstairs. Do we have what we need for these patients? So everything runs smoothly. Very important. All right, so briefly, let's move on to anatomy. I'm not going to get into a huge, big lecture on anatomy because, we could spend weeks and months just on anatomy, but you do need to understand just the very basic understanding, so you can basically also kind of anticipate what the surgery may need. Okay, so let's get these two definitions, anatomy versus physiology, because you hear those two terms together pretty often, anatomy and physiology. It's a whole class. So anatomy is the study of the structure, how it's made up, and then physiology is function. So that kind of has the same sound, spelled different, same sound. FF, physiology, function. Okay, that's the easiest way to remember it. And anatomy is the structure. So we're studying the structure and function of the human body. So I put this little pyramid, whatever you want to call it here, to show you how the human body is made up. So actually, we're going to start here at the top, and all of us are made up of atoms, hydrogen, oxygen atoms, whatever. That is the chemical level. So you have to start at the very base before you can work your way up. Everything else is dependent on this, the chemical level. Okay, so chemicals help make up a cellular level. So cells are made up of chemicals. So cellular level, there's a lot of different types of cells in the body that each have a specific function, okay? When you start to combine different cells that have a common function, you're going to make tissues. So cells working together for a common function make up tissues. There's, again, a lot of types of tissue. Here's just a picture of a smooth muscle tissue. You have smooth muscle, you have skin, there's nervous tissue, for every part of the body. So when you group together tissue to have a common function, you're going to make it an organ. So here's a picture of a bladder. That's one organ, your stomach, your intestines, eyes, skin, those are all organs, okay? When you combine different organs together that have a common function, again, two or more organs working together, forms the organ system. So your digestive system has a lot of types of organs. Your stomach, your small intestine, large intestine, etc. Those are all part of the organ system. When you group together every organ system, you now have the organism, which is you, a human. All right? So let's break down some of these organ systems and what they are really each referring to. So we'll start with the skeletal system. There are a lot of surgeries that we do on the skeletal system. So there are 206 bones in the adult. Now the skeletal system also includes not just bones, but also tendons, ligaments, and joints. Okay. So common procedures I just threw in here that you might see are related to the skeletal system and ORIF. Memorize these abbreviations as well. I didn't put them earlier, but here they are. ORIF stands for open reduction internal fixation. So let's say they break there. Let's find it. Maybe radius and ulna. Pretty common if you're falling. Catch yourself. Radius and ulna. We have to maybe make an incision into the skin to expose these bones and their fractures to fix them. And we're going to fix them with plates and screws. So opened the skin. Reduction means putting the bones back where they go in line. And internal fixation, we are fixing them from, inside the body with plates and screws. You could do it closed reduction where you don't make an incision and maybe put pins through the skin. That could be an option. TKA stands for total knee arthroplasty. So plasty is basically like fixing something. You are surgically repairing it. And arthro we learned was joint. So we're repairing the knee joint. This is one where we're going to put in implants to make a new knee. THA is very similar. Total hip arthroplasty. Total is because we're taking all the parts of the joint and replacing it. Osteotomy, you're just making an incision into the bone. Okay, a couple others. Muscular system is the whole purpose for that is movement. They do relate it very closely to the skeletal system because most of our muscles are attached to bone, but there are a few that aren't. Smooth and cardiac are not attached to bone. Smooth muscle would be an example found in your bowel, and it moves the food. It's still for movement, but it's moving the food down the line, okay? Cardiac muscle, still for movement. You're pumping blood through the heart. So skeletal is the only one that you have conscious control over. Smooth and cardiac is unconscious or automatic. Your body just does it. You don't have to think about it. So some procedures related to the muscular system. This term here, fasciotomy. So incision into the fascia. So fascia is a really dense connective tissue that surrounds bundles of muscle. So you're going to see it on the outside of muscle. And sometimes we have to cut into it to relieve pressure. Maybe there was a fracture and we have to relieve that pressure, or you're going to cut off blood supply. So herniorrhaphy. Now notice how that's pronounced. It's not herniorrhaphy, okay? Herniorrhaphy. It's kind of hard to say. Herniorrhaphy. So rhaphy we said was to suture. We're suturing what? Hernias. So a hernia is like a weakness in a layer of something. Sometimes it is the muscle layer or the fascia layer. And then whatever's underneath that protrudes through it. It could be bowel, in which case would be usually an emergent procedure because you don't want the bowel to lose blood supply. So different types of hernia repairs, lots of different types. Or you could do a muscle biopsy. Maybe they suspect there's cancer. That is possible. So they'll take a tiny biopsy of muscle to send it to the lab. All right, another system. The nervous system is what we use to respond to any type of stimuli, information that's coming into our body that we need to have a response to. So in this system would be the brain, spinal cord, nerves, and neurons. The neurons are those individual cells that are capable of carrying out an electrical impulse, which means you can send the signal to the brain or back to whatever needs to move, maybe your hand. Those are neurons. So they're the main type of nerve cell. Procedures related to that would be craniotomy. So we learned this one. Otomy, an incision into crani, the skull. Maybe we have to relieve pressure on the brain. Maybe there's a tumor, you know. ACDF is anterior cervical discectomy and fusion. So an anterior means front of the body. So you're going to make an incision from the front side of the body to go to the cervical portion of the neck to take out the disc and then fuse those vertebrae together. And then the last one here, carpal tunnel, is actually what this picture is down here. So it's a small incision. It's right on the wrist, right here, okay? So we do this to relieve pressure on this nerve that runs right through the wrist. It's the median nerve. So super small. So make sure you're pulling the right tray for these. You don't need big, long retractors or anything like that for this type of procedure. Very superficial. Okay, two more. These kind of go hand in hand too, pretty often. So the reproductive system, obviously to make more humans, that's the whole point, reproduction of humans. So procedures related to this would be orchiopexy. Talked about this one at the beginning. D and C, here's another abbreviation you need to memorize. D and C stands for dilation. I've also seen it dilatation, same thing. Dilation and curettage means to dilate, in this case, the cervix, and to curette means to scrape. So you're going to scrape out the inside of the uterus. Usually these patients have maybe abnormal menstrual cycles or painful, difficult menstrual cycles. So this will actually help with that by scraping out that endometrial lining of the inside of the uterus. And this last one, notice how this is pronounced, okay? Pelviscopy. There's a little bit more emphasis here in the middle. Pelviscopy. It's not pelviscopy. It's not scopy, okay? So it's also important to learn how to pronounce these, because if you, like, look over here, cystoscopy. If you pronounce it cystoscopy, they're kind of look at you like you don't know what you're talking about, because that's not correct, okay? So learn how these are pronounced as well. Pelviscopy. So to view inside the pelvis. It'd be a small incision to look inside the lower abdomen area. Okay, urinary system. This is how we typically remove waste, especially from the blood. Filters the blood. Every second your kidneys are filtering blood and getting rid of things that your blood doesn't need. Maybe it's excess water or certain minerals, etc. Typically, you won't see blood. You shouldn't see blood in your urine, or there's a couple proteins are usually too big, so you shouldn't see those in your urine. So in this system, you would have kidneys, ureters, urinary bladder, and urethra, and it goes in that order if you're going from top to bottom. Starting at the top, kidneys, ureters, bladder, urethra. Procedures here, like I said, cystoscopy to view inside the bladder. That's what this particular instrument would be for. This is a cystoscope. So the scope is the instrument used to view. This is a rigid cystoscope. You could have flexible. A nephrectomy, excision of what? Nephr means kidney. So excision of a kidney. And then lithotripsy is to break up, litho meant stones, so to break up stones, kidney stones or bladder stones. All right, respiratory system. This is how we breathe. So you're inhaling oxygen, exhaling carbon dioxide. So these are the main organs here: nose, pharynx, larynx, and working our way down again, trachea, bronchi, and then lungs. You could break these apart a little further if you wanted and include alveoli, bronchioles, but we're not going to. So procedures: thoracotomy, otomy, incision into the thorax. This is your chest cavity. So incision into the chest cavity, and it's kind of vague, thoracotomy. Why, there might be something else attached to that term, like why are we doing the thoracotomy? Are we doing a wedge resection of the lung? Who knows? So pneumonectomy, excision of, pneumo means lung. So either the entire lung or partial. Tracheotomy, you're making an incision into the trachea, usually right here in the front of the neck to help them breathe. ESS stands for endoscopic sinus surgery. So usually we're going to go through the nose with a small camera and clean out the sinuses. All right, digestive system. You put in food for fuel, right? Or for comfort, whatever. Mouth, esophagus, stomach, small and large intestine. Those are the main organs. There are a lot of accessory, but those are the main players here. So bowel resection, this term really doesn't, you could say colectomy, if you wanted to say it that way. So excision of the bowel. Appendectomy, excision of the appendix. Appendo is appendix. Gastrectomy, excision of the stomach. Maybe it's for cancer, maybe it's for gastric bypass. Okay, this instrument here I put for digestive system, this is an Allen clamp. Looks very similar to a Coger clamp if you've had surgical instrumentation, because it has a little tooth here in the end, but these longitudinal serrations make it an Allen clamp. It's a traumatic bowel clamp. Clamp the bowel straight across to remove it. A couple more here. Circulatory. That's our blood pumping through our body. So you've got the heart, blood vessels, valves, all of that. Delivers nutrients to the body. All that oxygen you just breathed in gets put into the circulatory system for each cell. Goes all the way down to the cellular level. So procedures here would be CABG. We talked about that. That's coronary artery bypass with grafting. And arteriotomy is very common. Otomy, incision into what? The artery. Incision into an artery, cutting into an artery for access. AAA we've talked about. And then lymphatic system is also closely related to the circulatory because they both are basically circulating something. Circulatory system is a closed circuit in that it can just keep going. The lymphatic system is open. It only starts, near tissue, anywhere in the body, picks up that fluid in the tissue, puts it in lymphatic vessels, and then empties it actually back into the circulatory system later. So you'll have lymphatic vessels that look similar to blood vessels, but they're different. And then lymph nodes. So if you've been sick, maybe you felt a lymph node in your neck or something. Whoops. A little happy there. All right. Procedures here related to lymphatic tonsillectomy. A lot of you have probably had your tonsils taken out as a kid. I think they're doing that less and less now, but maybe you did. Those are actually lymphatic tissue in the back of your throat there. Tonsils are lymphatic tissue. So ectomy, excision of the tonsils. You actually have 5 tonsils. The 2 that you excise often are the palatine tonsils. You also have lingual that are further down that we typically don't take. And then 1 adenoid is technically a tonsil as well. So they often say this separate though as adenoidectomy. So it's actually closer to you go straight back from your nose to the top of the throat. And then sentinel node biopsy. So this is super common when you're doing maybe a breast biopsy. They suspect maybe there's breast cancer. They want to see if it's metastasized or spread to the rest of the body. And the way the lymphatic drainage system works in the chest, if you've ever seen a picture of it, everything in this chest area drains into the axilla, the armpit. So if you can follow those lines of lymphatic vessels and lymph nodes, you're going to test those lymph nodes to see if anything drained out of the chest area into the armpit. Because if it did, it's metastasized, and then you can see where it would go from there. So we would check those sentinel nodes, like the first node it would come to in the axilla. We would remove that first node to see if it's cancerous. If it comes back cancerous, we might take the next lymph node down the line in the vessel. If that's cancerous, they may stop there, they may take a third, but they don't go very much further than that. But if that very first node they come in contact with is not cancerous, then you can assume that it has not metastasized, because if it's not in the first one, it wouldn't be in the second one. That's the logic there. So you would need, for these, a small instrument tray. You're not going to go very deep in the axilla or the armpit, but you'd need basic dissecting instruments. This picture here actually should have been on the previous page. This is, well, I guess I could go with tonsils, because it's a mouth gag. You prop the mouth open. All right, so let's kind of transition into microbiology. Again, we're going to just keep it very basic because we could spend classes upon classes on micro. So it is important for you as a sterile processing tech to know microbiology, because you're going to be cleaning all of these things off of the instruments in decontamination. So you need to understand what they are, the danger to the patient or you, and help prevent personal exposure to these microbes. You don't want to cause any injury to yourself either. So microbiology means the study of microorganisms. Micro is tiny, small. So that includes bacteria, viruses, spores, things that you cannot see with your own eye. You need a microscope. Okay, so when we're talking about micro, 2 important definitions you have to remember, and I've mentioned, I think, this first one in passing at least. Sterile means the absence of any living microorganism, including spores. So if you have an inanimate surface like an instrument, there cannot be a single living microorganism on that, including a spore. Spores are like the harder version of bacteria to kill. So you have to get rid of even the hardest thing to kill. Otherwise, it could still cause a disease in patients. So we render something sterile by using a variety of sterilization techniques or processes that we'll learn in a couple weeks. There's steam sterilization. You could submerge it in something that would render it sterile. So depends on what the item is how you would determine the sterilization process. And then this other term is the opposite. It's contaminated. So it's on 1 or 2 things. It's either sterile or it's contaminated. There is no gray area. That is super important to remember, because you can't say, well, it's kind of sterile. It's not kind of sterile. It's contaminated, okay? There is no gray area. It is or it is not sterile. So if it is contaminated, it is soiled by infectious organisms. There is something that has touched that from an object that was also contaminated. There's pathogens present. on, like this is very obvious because you can see it, but sometimes you can't. So you have to just use sterile technique and understand maybe in this instance, something potentially touched it. So you're going to hear us say a lot, when in doubt, throw it out is, is what we use a lot in surgery. If you ever question whether or not something is sterile, it isn't. Okay, so when in doubt, throw it out. Just get rid of it. It's better to be safe than sorry. So when we're talking about microbes, what do they need to survive? Or particularly bacteria, because viruses are a whole different thing. So bacteria might require certain oxygen, temperature, or other conditions for them to survive. It's not all one size fits all, okay? Different bacteria require different things. Some love oxygen, some require oxygen to survive. Those would be aerobic. Aero means air. So aerobic needs O2 or oxygen. Anaerobic is the opposite. They don't need oxygen to survive. They can live deep in those tissues of the body and still thrive without oxygen. And then the term facultative means it can go either way. They don't care. They can survive with or without oxygen. Temperatures here, psychrophile. Phile means, this suffix here, phile means like loving or needs, essentially. Psychrophiles, cold. They like cold temperatures. Mesophiles are moderate. And then thermophiles are, they like warmer temperatures. And other conditions, that require some bacteria to survive are pH levels, whether something's super acidic or basic, they might prefer one over the other. Nutritional needs, maybe they require a lot of simple sugars or something like that. And then moisture, humidity, and humidity play a big part in a lot of them too. A really damp, humid environment, some just proliferate in. So I like to throw this picture in here. I wish I could take credit for this. I cannot. I just found it on, actually on Pinterest. But I always show this to all of my classes because I think it's important to know what these bacterial shapes are, and if you can relate it to something that, you might remember easier, right? It's a little bit better. So these are bacterial shapes in cat form. Okay. Why not cat form? So these are the terms here, and relates to the cat. So coccus is round, a round like berry shaped is sometimes what you'll hear it called. Coccobacillus is kind of in between these two, 1 and 3. It's kind of round, but it's kind of long. So this third one, bacillus, is rod-shaped bacteria. Vibrio is comma-shaped, like kind of like a comma you would use in writing. And then spirillum is pretty easy. It's kind of in the name. Spiral, a spiral-shaped cat. Spirillum. And then pleomorphic, notice there's 3 here because pleomorphic means it can change shape based on its environment. Maybe it needs to be round to bond to something else or to attach itself. But pleomorphic changes shape. So I just threw that out there for you to, hopefully you can remember those shapes. All right, so pathogens of human concern. Pathogens, this term here just means anything that can cause a disease. And typically we're talking about in humans here. So as far as bacteria are concerned, you're going to see these pretty often. VRE stands for vancomycin resistant enterococci. So vancomycin is an antibiotic. There have been a lot of bacteria over time that have become resistant to certain antibiotics. This enterococci particularly is resistant to vanc. So you're going to find this in feces, urine, and blood, and it is contagious. It will cause disease in somebody else if you don't use the right contact precautions. Klebsiella comes from the intestinal tract. There's a lot of Klebsiellas. And then Staphylococcus aureus, super common. Have you ever heard of a staph infection? That's what this is, staph. Everybody has Staphylococcus aureus on their skin anyway. It is what we call a resident microbe. It belongs there. But what happens is, especially in surgery, when we make an incision into the skin and that pathogen could potentially go deeper into the tissue, that's when it becomes a problem. It becomes what we call an opportunistic bacteria. It has the opportunity now to thrive and, you know, proliferate deeper in the tissue where it wasn't before. So typically we find in the skin and sometimes also in the nasal passage of some people. So notice, just to point out, when we're talking about bacteria, they're italicized. Okay, that's typically how it should be seen. And then there are two names here. We call that binomial nomenclature. So this is the genus and this is the species. I know that's some weird terms there, but you might have a lot of different types of Staphylococcus, but there's only one Staphylococcus aureus type. You can have a Staphylococcus epidermidis. That's another type. Okay, so this last term is the very specific type of bacteria we're talking about. Okay, over here to viruses. Completely different than bacteria because bacteria are technically living. They don't have a normal cell structure like we have as humans because they don't have a nucleus, a true nucleus, and we do. But viruses don't even have that. They don't even have a cell structure like similar to us. They are non-living and they require a host cell. They have to go inside a host cell to replicate. Bacteria do not. They can replicate outside of a host cell. So examples here of viruses: HIV, we've probably all heard of that. Human immunodeficiency virus. These two especially are of huge concern for healthcare workers because of the way that they can transmit through blood. So these are blood-borne pathogens that we have to be very careful with because, you know, you're going to come in contact with sharp objects that come down to you from the OR. Make sure you're wearing your proper PPE because you do not want these. Okay, you can never get rid of HIV once you have it. You can treat some of the symptoms and manage it, but you cannot get rid of it. You can treat Hep C, but it is still going to do some damage. So both are bloodborne, and Hep C, hepatitis C, is the most prevalent bloodborne infection. So another type of pathogen that we're going to talk about is a prion. So this is unlike any other category. It's not like bacteria or viruses because what it is, it's an abnormal protein. It got folded weird and it's not normal and it's going to cause a different response. So typically these prions affect the brain and it can be in humans. There's some that affect sheep, cows, and I didn't put it right here, but it's also known as mad cow disease. Maybe you've heard of mad cow disease. So that is also CJD. So CJD stands for Creutzfeldt-Jakob's disease. That's the most common type of prion, especially that affects humans. And why this is so important is because it's extremely resistant to sterilization process. So our typical sterilization process, you know, 270 degrees for however many minutes, whatever it is, will break down and kill normal bacteria, spores, viruses, but it doesn't typically kill prions because they're not living, for one, and they're proteins. So you have to take special measures when we're talking about if you know something is infected with a prion. So it's typically spread through infected brain tissue, neurological tissue. So how do you handle those instruments? If you know a patient or suspect a patient has CJD, you have to be very careful, okay? A lot of times, and your facility may differ, it just depends. They will require disposable instruments to be used on that patient if possible. And if not, they may just, at the end of the case, bag up those instruments and throw them away or dispose of them properly. That way they don't risk it, okay? Because standard sterilization processes are not effective. They're ineffective. Everybody needs to know that this patient might have or does have CJD. You have to communicate that so someone doesn't miss something. You also need to contact infection control or the CDC because it's pretty rare and they want to keep track of those things. So disposable, heat-sensitive items should be used. Try to avoid using the super expensive equipment if you think you have to throw it away, right? So it's going to take some time to think through those things. Some might require them to be quarantined for a set amount of time, okay? And then all surfaces must be cleaned accordingly. So just a quick conclusion here on the microbiology section. This is what your job's going to be about. You're cleaning off those potentially harmful things that could harm you or the next patient that's going to use those instruments. So it's important to understand that those can lead to very serious illnesses in patients. They put different pathogens pose different risks. Okay, so it's important to take the correct steps in minimizing those. This little picture here, maybe I'm a nerd. I am a nerd, but I think these are cool. If you ever want to look up electron microscope images, this is actually a spirillum bacteria. It's been colorized, but that is a spirillum. All right, so let's talk a little bit more about infection control. Now that we've learned, the basics of microbiology and why you need to know it, you play a significant role in HAI. So this stands for hospital-acquired infections. So you could either stop that potential HAI, or you may miss something and cause an HAI in somebody, which we for sure don't want. So this is interesting. They've done a lot of studies on this. Poor outcomes, we're talking about patients, can sometimes be traced back to the central sterile processing department, if that's where you're working, because maybe instrumentation was not properly, broken apart before it was cleaned. Maybe they didn't pick the right sterilization method. Maybe package integrity was the issue. So think about those things. Every step of the way, it has a potential to become contaminated and lead to an HAI in a patient. Okay. So you're always going to check the IFUs, making sure you're processing that according to the standard. That way it does get sterilized properly. So the chain of infection looks something like this. So when we're talking about how does that bacteria or virus move on to the next? Okay, so what are our infectious agents? We've talked about these. We didn't list too many fungi or parasites, but that's your microorganism that causes a disease, your pathogen. Then where does it go? We're going to go clockwise here. It's going to go into a reservoir. Okay, people, food, water, whatever. So the place in which the infectious agent lives, grows, and reproduces. From the reservoir, it's going to exit that reservoir. Okay, ways in which it leaves that reservoir could be blood, secretions, excretions, skin. Okay, from there, it's going to find a way to go to a susceptible host, the next person down the line. All right, maybe you sneezed. Maybe your portal of exit might be an excretion, mucus, and you sneezed it out into droplets into the air. So that's your mode of transmission. It's important to understand how certain bacteria have different modes of transmission, because we can stop it there. We can put on a mask. We all learned that through COVID, right? We can wear gloves for physical contact. Okay. So then if none of those got stopped, you're going to go to the portal of entry. So how did it get into the host? It left this reservoir, but how did it actually get into the host? If I sneezed and didn't have a mask on, it's probably going to enter the respiratory system or even mucous membrane in the nose to the next person. Okay, so different ways it could enter. And then it's into the host, your susceptible host. A lot of things can affect how severe maybe that infection might be. Maybe you don't even get an infection. Your immune system is strong, right? A lot of our patients, if they're in the hospital, typically their immune system may already be lower. Their body is fighting something else off, so we don't want to make it even harder on them. So maybe they have a lower immune response or immune deficiency. Maybe they are diabetic. Diabetic patients have a harder time. If they have burns, they're completely open areas of skin, they're very susceptible. If they're already in surgery, they're going to be susceptible. And then our older patients are very susceptible as well. And then it just continues. The whole chain of infection continues if you don't stop it. So it's important to know each step of those. All right, when we're talking about infection control, we have to talk about asepsis. So remember A at the beginning of the term? This is a prefix. We're talking about without or none. Without sepsis is infection, without infection. So principles of this is preventing infection or breaking that chain. So we're talking about medical asepsis. These are things that you can do every day just normally. You practice clean technique, make sure things are clean. You're washing your hands constantly, and doing proper decontamination steps. Surgical asepsis is a little different because if we're talking about surgical asepsis, we are trying to make things sterile. So that includes sterile technique, making sure we don't contaminate something when it's sterile. So no spores. So those 5 basic principles of asepsis include know what is dirty and contaminated. Sometimes we just have to use critical thinking skills to say, you know what, if this fly landed on my back table of sterile items, everything's open and sterile, but a fly lands on it, even though I can't see what the fly left behind, it's contaminated. Okay. So we can't always see when something is dirty or contaminated. Number 2, you have to know what is clean. So you have to make sure you're checking your items to see if they've been properly sterilized. Check your chemical indicators. Know what is sterile. Again, impossible to see if it's sterile or not. You have to use your critical thinking aseptic technique skills. So something is only sterile if it went through the sterilization method and your biological indicator has changed and it didn't grow anything. Number 4, keep the first 3 conditions separate. Okay. You have to keep clean and dirty separate. I'm going to say this a lot. If you're like grouping all your dirty stuff right next to your clean, what are the odds of it staying sterile? Very slim, okay? And then number 5, remedy contamination immediately. Don't wait around. Fix it right away. Otherwise, that contamination could spread and make it even harder to contain. Okay, talking about safety and risk management because we're talking about infection control. We have to mitigate those risks. So most hospitals will have a whole department dedicated to risk management. Their whole purpose is to make sure, A, that our patients stay safe, and so do you, as the worker. So they focus a lot on injury prevention. If something does happen, you have to write an incident report. It goes to them, and they're going to find ways to make sure it doesn't happen again. So ways that you can mitigate risk to yourself. Wear the proper PPE. You guys have already talked about that in your discussion posts. Understanding what the purpose of those are. Follow OSHA and TJC standards. So OSHA is your occupational safety and health, and then TJC is the Joint Commission. They're the ones that come in and accredit each hospital or healthcare facility, making sure their standards are being followed. And then IFUs again, and sharp safety is a big one so we can prevent those bloodborne pathogens. So sharp safety, a little bit more about that. These pictures are all examples of sharps containers. You'll see these everywhere in healthcare facilities because, there's always needles. We're always giving patients shots, whatever. You have to make sure that you put the sharps in the proper containers. They cannot just go in regular trash. So sharps injuries can result in, we've already learned about these 2, HIV, Hep C, and a lot of others. So always handle sharps with care. Never grasp, if you're like in decontamination and you have a bunch of instruments that got sent to you that are dirty, don't just reach in and grab like a whole handful because you don't know what could be in the middle of that handful. Someone may have accidentally left a loaded blade in there. That happens. We're human. I mean, obviously there should be some care involved, but maybe they left something in there that could potentially hurt you. So be careful there. Always point sharps away from your body and put them in the appropriate container. Okay, you're also going to be doing a basically a research paper on material safety data sheets. So it's important for you to know that the chemicals you use in sterile processing can be very harmful to you if they're not handled appropriately, or if something happens, you need to know how to handle it. So we used to call them MSDS, material safety data sheets. They dropped the M. I don't know why. Now they just call them safety data sheets. What it is an entire, I mean, they used to be printed, but now you can just call a number and find whatever chemical you're talking about, but it lists literally all these things. What's in it? What's its makeup? What could it do to you if it comes in contact with your skin or your eyes, or if you accidentally ingest it? So what would you do to treat that? What are the first aid procedures? Is it flammable? What's the fire info? Some of these are very flammable, and you have to take special considerations there. So it's important to know where you can find that SDS and how to handle those types of chemicals. So along with a fire risk here, it's important to know this fire triangle. We talk about this pretty often because, especially in sterile processing, you're going to have all these things nearby, okay? And in, this one's particular to surgery, but it's the same concept. You're always going to have heat. There's a fuel and oxygen. If you have all three of those things, you can have a fire. The fire potential is very high. So if you eliminate one of these things, if you get rid of the fuel, whether it's the drapes or the alcohol solution, get rid of that and you can eliminate the potential for fire. So oxidizers include obviously oxygen, but also nitrous oxide. Igniters are things that might cause a spark, laser, cautery, hot lights from the fiber optics, okay? So the idea here is don't give fire a place to start. So minimize these things here. Right, so some other safety concerns you need to keep in mind. Going back to sharps here, foaming detergents can conceal sharps. If you've sprayed foam on something to start the cleaning process, you might have just hit a loaded blade, so be careful there. Never just reach into a sharps container. Maybe you dropped something you needed. It's really too bad. You're going to get stuck if you do that. Never unload blades by hand. If we have scalpel blades in surgery, you need to take a needle holder to unload those scalpel blades. Never do it by hand. Some things come out of sterilizers at very high temperatures for like immediate use steam sterilization. Always protect your hands. That's super hot. It was just in there for like 270 degrees. It'll burn you. So again, use caution with any sterilizer if it's hot. And then follow ETO safety guidelines. ETO is ethylene oxide, and it's one of those chemicals that could be potentially very harmful. It's flammable for one, and two, it's a known carcinogen. It can cause cancer. Okay, so hopefully, I know this is a lot of information. It's not typically this packed and this long, but there's a lot of important things here that you need to remember as far as med term, micro, anatomy, keeping yourself safe from those bloodborne pathogens, etc. So I like this quote here. At any given moment, we have two options: to step forward into growth or to step back into safety. So, I know we're in week 2, but maybe you're getting close to the end of your career here at Herzing. Maybe you're almost done. I don't know where you're at in this process, but just remember, you're doing this for a reason, and maybe things are starting to get a little difficult. Maybe, life is throwing you a curveball, but remember why you're doing it. You're trying to better yourself and, educate yourself and give yourself opportunities down the road, to make something. So keep going. I know it can be difficult, but you're working towards growth. So if you have any questions, please reach out to me, mludwig@herzing.edu. My office hours are on Tuesdays. If that doesn't work for you, we could try to work something else out. Just let me know, okay? But reach out if you have any questions. All right, have a great week.